discussion. May I invite Dr. Reena SETHI? And this is the last talk for this session. So
very good morning to all. Thank you so much for the opportunity. We all know that there have been a lot of advances in intraocular lenses, and that's because we are using more and more intermediate vision. So most of our activities are now the screen and a little beyond. So presbyopia correcting IOLs have changed the game of refractive cataract surgery. The treatment option has grown increasingly, and so we're going to discuss what exactly are the options. We could have a diffractive bifocal and a trifocal. It could be accommodating or pseudo-accommodating lenses, or the extended depth of focus, or the extended range of vision lenses. So these category of different lenses have different techniques that are involved in these intraocular lenses. The diffractive, bifocal and the trifocal, they aim to focus at images which are more than one focal plane, as we all know. The accommodating work on the action of the aim to changing the optical power of the eye, and the extended depth of focus, they create an elongated focus to enhance the intermediate vision. So what is going to be your approach when you have a patient of cataract? You should always remember that no one size fits all. The focal points and range differ in different technology IOL. So we must first be convinced about the technology of the intraocular lens, rather than finding it out what happens to the patient. The EDOF and the trifocal IOLs to be used in a very customized fashion. You can always have an EDOF in one and a trifocal in the other eye, but you have to customize it after weighing the pros and cons and what exactly is the expectation of the patient. And always remember that what you feel has been a 6x6 and an N6 vision is could be not very comfortable for the patient. So patient satisfaction is more important than the Snell's equity. The preoperative evaluation has been very detailed. You must understand what is the visual goal for the patient, give them enough chair time. They need spectacle independence, so understand what exactly is their day-to-day activity in which they are requiring the spectacle independence and the compromise that is acceptable to the patient, because no lens is as good as your own natural lens. So there are pros and there are cons which have to be explained to the patient, and let the patient make the choice. Patient education is very important, and staff education is also very important, because you all as a team need to make the patient understand the same requirement and the same goal. Prerequisites, these are very mandatory. You must have a good biometry. Do the biometry maybe at least 2 times or 3 times for the patient, if possible on different occasions. And management of the ocular surface disorder is very important, because of the increased screen time. Most of your patients are having dry eyes, so that has to be assessed. And detailed macular OCT on all patients is mandatory. Trifocals require a very healthy eye, so avoid them in patients of diabetes or where they're having uncontrolled diabetics, like already explained here. And EDOFs are more forgiving. So what is the EDOF lenses that are happening now? So there are a lot of EDOFs because these lenses are more forgiving. So they introduce the positive and the negative spherical aberrations, and these aberrations help expand the patient's overall depth of focus. So there are various types of EDOFs which are there. What is the scientific difference between all these lenses? The monofocals, if a patient requires only good distance, then monofocals cannot be beaten to it. They give you a very good distance visual acuity. But the EDOFs and the trifocals also do well and are comparable to monofocals often. The intermediate, the EDOFs and the trifocals are comparable. And when a patient is really requiring a lot of near vision, like sewing, needling and all those stuff, then trifocals are a clear choice. There are different scientific differences in the halos and the glares also, because the trifocals have a design of the gaps, and these gaps cause different phase reversals, and this leads to a visual fluctuation. The EDOFs, especially the latest EDOFs, non-diffractive, don't have these gaps, so these side effects are very minimal in these patients. So which are the emerging technologies? You have the small aperture technology in the EDOFs. Now in this, what happens is there's an embedded opaque annular mask, which is a little away from the center, which blocks the unfocused paracentral rays. So allowing the central path which is going to give you the distance vision. Then the bioanalogical analogic type of EDOFs, the refractive power is highest in the center and gradually it tapers on the periphery. The echelate design is also there, which has the incorporation of the diffractive echelate optic designs. So try and understand what exactly is there in these EDOF lenses. So what is going to be my approach? My approach is going to be that it is very important to tailor the preoperative visit to the patient's unique needs, as I discussed. The administer an in-house questionnaire to determine what exactly is the patient's need and keep it very simple. So what are the questions you have to answer? What is the patient's current refraction? What are the patient's post-operative visual goals? What can the patient afford? That is very important. The affordability is important because you need to tailor the requirements according to the affordability also. And what is going to be your recommendation? You can recommend, but let the patient decide for himself. Always remember, the myopes have always enjoyed a very good near vision. So they would be happier with a trifocal or a monovision EDOF. Listen to what they want to achieve. It's customization today. So customize the right eye, customize the left eye, and customize the need, total or overall need of the patient. And explain why a technology is or not recommended, and also financials to be discussed and addressed, because that's important. Goal is not to just help them see today, but have faith in the technology so that you can offer that it's going to last for a longer time or forever. So these are a few studies on the comparison of the EDOFs versus the trifocals, in which we've seen that the multifocals are ideal for the visual acuity at 3 points, the near, the intermediate, and the distance. But they still cannot have satisfying visual quality between the separate foci. So that's how the halos and the glares are there. And also the uncorrected distance visual acuity and the intermediate visual acuity in these lenses, there is no significant difference between the monocular group in these cases. EDOFs have always can provide better binocular uncorrected intermediate, but worse near vision. So trifocals have an edge over this in these patients. And we have to study the defocus curves for this, and we know how that the EDOF gives a better intermediate vision. So patients who are requiring more of screen time, digital screen time on their executives in offices, and EDOF is a very good option for them. Contrast sensitivity, there's not much of a difference between the EDOF and the trifocals. That's what the study says. And the quality of patient and patient satisfaction is also very much compatible, or between the patient satisfaction also very similar in these groups of patients. So what we need to also, I'll just quickly run through these slides because of the time. So this is a comparative valuation of diffractive trifocal and the newer generation, a couple of new generation EDOF lenses. And the EDOF design in the Lucidus IOL achieves a lower rate of glare and in the early period. That's what in the study was done. So we don't have many long-term studies with other different lenses. We have more on the Vivity and the Panoptics comparisons. So certain intraoperative pearls, you must have a certain 5.5 millimeter rexes. IOL centration is very important. When you leave the eye, just see that your Purkinje images are clear. Polish the capsule, this is one step, please take time over it, because post-op satisfaction is because if the capsule is clear, you'll have good. And manage the astigmatism. These lenses are more unforgiving if the patient has astigmatism. So meticulous removal of viscoelastic is important. An unhappy patient, listen to the patient, discuss and address the issue, and take care of the residual refractive error with whatever modalities you feel comfortable with. And in conclusion, it's very important to select the right patient, education of the patient, the accurate biometry, match the IOL with the patient lifestyle, and last but not the least, an excellent surgery is very important. And we are actually very much in chase of the ideal IOL it's getting heated up. I'm sure it's going to be a good maybe a newer EDOF or a newer trifocal that's going to take over, and it won't be wrong very soon that the era of under-promise and over-deliver is going to be the end of it. Thank you so much.